We're the strategic national sector intermediary for a range of health and social care organisations. We've got nearly 500 members, including a large network of national and local third sector organisations. We have a growing number of associates in the statutory and private sectors, and individuals who want to be involved, individuals themselves with long-term conditions who want to be involved in the debate. And many of our NHS boards and support boards and community and health partnerships are associate members. And our vision is noted in the slide here, and it tries to capture the idea of putting people at the centre of services. And we try and do this through three core aims. We seek to ensure people are at the centre, that their voices, expertise and rights drive policy, and that they sit at the heart of design, delivery and improvement of support and services. We support transformational change towards approaches that are preventative and that work with individual and community assets, supporting human rights, self-management, co-production and independent living. We also champion and support the third sector as a vital strategic and delivery partner and foster better cross-sectoral understanding and partnership. So that means that we're a strategic partner to government, we're a critical friend to government, but we ensure that the focus remains on the real lives of people, families and communities, and we help to ensure that their voices are the voices for change. And for those organisations that are working in health and social care, the stark statistic that faces them is that 4 in 10 people in Scotland live with at least one long-term condition or disability. And I'd like to say a wee bit about the background to this. 2 million people living with one or more conditions. A quarter of those with long-term conditions have 3 or more conditions. And you're going to have a lot more discussion over the course of early next year around something called multi-morbidity, or multiple conditions as we call it. The impact of living with one or more conditions. The prevalence of people living with long-term conditions, which increases with age, and we live in a time, fortunately, when people are living longer, but that's going to bring its own problems. The prevalence of long-term conditions set to rise kind of exponentially, really, and there's been a big publication this week about dementia, as you'll have seen. The impact on GP consultations and inpatient bed days and emergency admissions and prescription medicines, all to do with people with long-term conditions. That correlation between long-term conditions and mental health challenges is very, very strong. And finally, that works across the system. It drives health inequalities. It's affected by income. It hurts employment, and it leads to social inclusion. It presents a whole system challenge. And I guess the challenges for health and social care set against falling resources is also clear. And although the proportion of older people is a primary factor, as I've indicated there, issues like welfare reform and a relatively high unemployment rate are also driving greater need amongst children, young people, and working age adults who are disabled or living with long-term conditions. So that's a backdrop position for you. I'd also like to take you through some information about the third sector in Scotland. And I think it will surprise many of you to see that description of the third sector. It's a sector that's sizable. It's got a significant workforce. There's a huge number of organisations dancing in and around the statutory sector. There's a major volunteering effort throughout health and social care systems, increasingly qualified and accredited, with a huge, invisible but tangible economic product. There's a big trend towards trading in public service contracts. And Rita will be interested to know, but the procurement bill that's going through just now is likely to be amended to exclude health and social care organisations from the requirement to go to tender or re-tender. That's just kind of hot off the press. I feel a bit like breaking news. There should be a strap line under me here. And that will be a major step forward. It'll be a major liberator for those authorities that are keen to be involved in it. And again, more importantly, there's a pedigree of experience and adaptation in the sector, the third sector. And many of the organisations, some of the organisations I've mentioned just now, for example, predate the NHS, some by 100 years predate the NHS. So it's that pedigree. But what else is there? You know, it's a values-driven sector. It's already person-centred. It's linked in locally and nationally. It has huge reach, very extensive reach. It's generally innovative and flexible. It's generally trusted. It also is not risk-averse. It's responsive. It's keen to take risks. It's keen to build service changes. And it acts as a catalyst out with mainstream funding. But I wanted you to see some of the members that are there. And I could do 20 slides like that. But you'll see that range of membership there. And just to say a wee bit about some of them. Chest, Heart and Stroke Scotland, presently financing more than 30 major research projects in all of Scotland's leading hospitals and medical schools. And just this week launched the Stroke Charter, which I would encourage you all to sign up to. Diabetes UK Scotland, who drove the Diabetes Action Plan, who won a major campaign for insulin pumps last year and host the National Care Line service. Penumbra, a contracting organisation delivering mental health services in about 36 of our 36 community care services throughout the local authority in Scotland. Macmillan Cancer Support, a major investor into the NHS, currently developing a Transforming Care After Treatment programme, a 3 to 5 year programme that is investing into the NHS, as well as all the traditional Macmillan Nurse type activity it does. It fights on unclaimed benefits, it fights on fuel poverty and prescription charges. Breakthrough Breast Cancer, currently funding a research unit at the University of Edinburgh, which has discovered a potential new way to treat a common form of breast cancer, which affects 9,000 UK women each year. Alzheimer's Scotland, again, very much to the fore in relation to dementia care standards, in relation to the National Dementia Strategy, in relation to human rights for those with dementia and their carers. A big local partnership with the University of West of Scotland, a training relationship with Ayrshire and Arran Health Board. And Sam H. running the very successful, internationally acclaimed CME anti-stigmatisation campaign. And I could go through every one of those members there, and the next 10, and the next 10, and the next 10, and I would give you a description of how those organisations contribute. But right at the bottom there, you'll see Voluntary Action Scotland, and this conference is hosted by one of the 32 interface organisations that work locally in Scotland. And Voluntary Action Scotland is their umbrella body, and Callum is their chief exec. And they're in a process, a strong process of representing and supporting third sector interfaces and their members to ensure that together, as a network, they can influence policy and services planning at national, regional and local level. So all of those bodies working around the systems that are in place. And important just to say a wee bit about this. If you're a politician, change only happens through significant change is only enabled by legislation, and that's a range of the legislation that currently impacts on this process we're involved in. I've called it the Health and Social Care Integration Bill because its Sunday name's a bit too long and I can't remember it. Public bodies, brackets, something. But the intention there, the underlying intention is to ensure closer working between health and social care services to achieve better outcomes, and to realise a shift in the balance of community care from institutional to community-based settings. The Self-Directed Support Scotland Act, again, crucial to ensure that there's a legal duty in local authorities to offer options to individuals whom they assess as requiring care and support. People like my son, for example, there, and requirement to drive that process. The current process of welfare reform, not being political here, having a devastating impact on many disabled and excluded individuals through the bedroom tax and other bits of the game. And not only a devastating financial impact, but a devastating emotional impact as well. Also important to talk about health inequalities as well. A high-level group meeting to talk about that. Why is it important? It's important because there's a gap, a health gap in the most deprived areas. Audit Scotland reported that men in the most deprived areas died 11 years earlier than those in the most affluent, with the age gap 7.5 years in women. And people in deprived areas also had higher rates of heart disease, obesity, diabetes, and problems with drug and alcohol abuse. Human rights, I'm going to talk about. It's much more important than simply espousing it. And the Human Rights Action Plan, which was launched this week, is going to have a significant impact, we hope, on all legislation over the next while, and we think it's going to have a significant impact on the legislation to come. We can't discuss health and social care integration without also discussing those policies and strategies that operate locally. And every one of those policies requires to have some kind of local connection, some kind of local drive. And it won't happen simply because Nicola Sturgeon or Alec Neil or Alex Salmond or anybody in government says it's a good thing. So that was my phone ringing there. And I just wanted to say something about this, because one of my pet foibles is huge national initiatives are the driving force behind people's working lives, and are very often invisible to people outside that closer circle. And that healthcare quality strategy that I've put up there, and you see the words there, and you just read them and enjoy them, I think. It does reflect that there's been a very significant change in the direction and travel and culture within the NHS. And Mandy who's with Chief Executive Hospice, was a Senior Director in the Ayrshire and Health Board, and she'll confirm that. There's been a renewed strategic vision starting maybe 6 or 7, 8 years ago around better health, better care. And that's been about improving patients' experience of care. It's about producing best value. It's been about focusing on health and well-being as an individual challenge. It's about looking at health inequalities in a much wider planning context. It's about focusing on anticipatory care and primary prevention, requirements to produce services for people with long-term conditions, interventions to give children the best possible start in life, and a focus on continual improvement. And that healthcare quality strategy enjoins all the professionals to engage the third sector much more significantly as we go forward. The irony for me is, and I was involved in that right from its kind of launch, and the first meeting I attended, I had to say, what about local authorities? Is there a local authority care strategy? And everybody around that table looked at me as if I was a Martian. I may well be a Martian, but you know, that business of focusing on the health sector only it was an issue. And although things have changed in 3 years, there's still a requirement for us to see a more seamless relationship. But that healthcare quality strategy is going to be one of the central drivers in relation to what we do. And currently, my colleague, Dr. Lisa Curtis, is there, and she's one of the directors who are driving the National Person-Centred Health and Care Programme. And we hope that we'll be driving the larger ambition towards a recognition that individuals are unique, that they need trust and empathy, and they need to be engaged in decisions about their healthcare and well-being. And that agenda for change that drives the health and social care integration process is there. And I've reduced that to a number of bullet points for you. I don't want to say too much about that. I just want to acknowledge that those are the issues. The ageing population, the need to take demand out of acute care, the need to take resource from the hospitals, the need to redirect it to communities, which is implicit in shifting the balance of care, the Reshaping Care for Older People programme, the fantastic work that's been done locally on the Change Fund, and Phil and Maria have been involved in that, the change that results, the change to services that has resulted as a process involved there, the way services are redesigned, the influence of health improvement for everybody, for all individuals, the drive to community action around that. What Harry Burns mentioned this morning is the assets model, building on the capacity that people have to be in charge of their own lives. And Matt's leading on community and capacity building and co-production for JIT, and that's part of the work that happens there. Self-management I'll talk about a wee bit, re-enablement and prevention, and co-production I'm going to mention later. Now, I think there's been great improvements through the NHS in relation to waiting times, leading-edge healthcare services, drugs, treatments, a fantastic patient safety programme. Now, amongst the best in the world, it has to be said, in Scotland. And equally, a developing track record of success through joint improvement team work, through SSSC work, through Coalition of Care and Support Providers work, through improvement service work for elected members and for local authorities. All those laying down a good platform for change as we go forward in partnership. But I need to say this at the outset, as we accommodate that agenda for change, it's fair to say that partnership working is a bit like trying to rebuild cities in war zones very often. There's always a new advance, there's always a defensive manoeuvre, a failed airstrike, there's always civil unrest, there's always lack of resources, there's always an unexpected insurgency, and the winter beds crisis will no doubt be upon us shortly. There's always lack of direction from a divided command control. But we who are in the middle of that, we need to understand the landscape in order to maintain a sense of forward movement. And we need to keep glancing at the horizon as the shells keep dropping. And that's the agenda for change. And we don't underestimate the landscape. It's a challenging landscape in Scotland. 32 local authorities, 14 territorial health boards, the special health boards, 32 community planning partnerships, 40 demitting community health partnerships, and all the new integrated boards that have been set up currently. All circulating around their strategic plans, their business planning, their corporate governance, their working groups, their communities of practice, their improvement plans, sometimes their recovery plans, elections and democratic decision-making, workforce development, heat targets, performance management, zero-based budgeting, all of those impacting an agenda for change. But we need to know where we are in this process, this landscape. Chrissy report has set a mood music, set a route map for Scottish public sector reform. And this piece of legislation sits within that cluster of services that constitute public sector reform. It requires a significant and wholesale shift to investment in prevention, to support and services designed and delivered through co-production, and a sustained partnership working process across national and local government, the health service and the third sector. And it calls for us to be more ambitious about the way we change public policy and the way services respond to societal need. I just want to mention that, and because everything else is built on, recently is built on the tenets of the Christie report. And they talk about co-production. Co-production has emerged over the last while as a process here, and we've wrapped it in the Alliance into what we've called people-powered health and well-being, and we stole that from an organisation called Nesta. We stole that phrase from an organisation called Nesta, and Nesta had devised or articulated a framework for co-production and that had those key characteristics. And it's driven by the fact that people's needs are better met when they're involved in an equal and reciprocal relationship with professionals and others, working together to get things done, not having things done to them. And that's the underlying principle, a transformational approach to delivering services. The public sector and citizens making better use of each other's assets and resources and contributing to better outcomes or improved efficiency. And there they are, recognising people as assets. And that's about transforming the perceptions of people from passive recipients of services and burdens in the system into one where they are equal partners in designing and delivering services. Building in people's capabilities to alter the delivery model of public services from a deficit approach to one that provides opportunities to recognise and grow people's capabilities and actively support them to put these to use with individuals and communities. Mutuality and reciprocity, and that's about offering people a range of incentives to engage, enabling to work in reciprocal relationships with professionals and with each other, where there are mutual responsibilities and expectations. And peer support networks, again, encouraging peer and personal networks alongside professionals as the best way of transferring knowledge and supporting change. And that business of peer support is very, very strong in a number of areas in health challenges, particularly mental health. And peer support is crucial in helping people through recovery. And that business of blurring distinctions between professionals and recipients, between producers and consumers, by reconfiguring the way services are developed. And all of that underlining why co-production is such a powerful tool for change as we go forward. And I just want to allude to this. My organisation wrote the strategy for government, the self-management strategy for Scotland, a strategy that's known about within health confines, but is just as pertinent as we go into social care services. And that process there, derived at through an open process with service users, defines what it means to be in charge of your own condition, your own approach. And I want you to think about that for all those of you who are living with a disability or a long-term condition. You live with that condition all the time in your own communities and in your own homes. You have very little contact with professionals, and that's why you need to be in charge. That's why you need to be able to manage that process. And self-management itself is part of that whole business of putting people in charge of their own destiny. So, we need to ensure that health boards and local authorities work better together. At crucial points in the last 15 years, there were opportunities to legislate that weren't taken, legislation for better working, and they haven't particularly worked, and that's why legislation is around just now. And the aspiration is not simply to improve how health boards and local authorities work better together. It's about how you significantly improve the lives of people, how you bring about new ways of making decisions, how we invest our public money and design services with and for people and communities. And in that context, it represents a real radical opportunity to reshape culture and practice for key local services. And if it doesn't do that, it will fail. And as we go through this integration process, I guess the message for us is that we need to be absolutely founded on the business of producing better outcomes for people. And we've learned some of that through Christie, and we've learned some of that through the Change Fund. And that focus on outcomes is really, really important in the legislation. That business of trying to make sure that we design a service that makes sure that the individual in front of you is better served by the process you're involved in is key to this. And that's the latest version of the outcomes. I say the latest version because part of the bill process, and I have to say this, the bill process thus far has been extraordinarily inclusive. There are about maybe 10 working groups around the Health and Social Care Bill, one of which is on outcomes, another one on commissioning, another one on governance, another one on finance, another one on commissioning, and so on and so on. And that focus on outcomes there has been really, really important. And you'll see there that group of 7 proposed national outcomes are backed also by a developing suite of indicators. And that process is a process that's developing. We're just butting up now against making sure that it maps against existing activity in other benchmarking processes through Solace or community care benchmarking. And the requirement, however, as you can see if you look through them, is that the significant impact now will be that every service that is out there will be measured against the personal outcome for that individual. And so that emphasis on personal outcomes, that could be a ramp for somebody who's got 3 months to live and needs to be getting out, and it could be other things. But that personal outcome is going to be really, really important. That's why focus on outcomes is crucial. And I'm heading towards the last bit and a bit of the process. But just to say also, in the week that the Scottish Human Rights Action Plan was launched, and the week in which the government endorsed the approach again, we're delighted to note that some of our concerns now about human rights in the context of this bill has been recognised, because we believe that it can do several things. It can help bring together the separate cultures in health and social care. It can ensure that focus on outcomes which the legislation wants, and it can embed those principles of co-production and participation through involvement and engagement that I mentioned earlier. And the value of a human rights-based approach can be seen in Scotland's work in dementia most clearly. It can be seen in the Care About Rights programme, which is about training frontline social care staff, and it can be seen in the work of the State Hospital. It's not a chimera. It's a real thing. It can be applied and it can be seen elsewhere. And I wanted to show you this short bit of animation to reinforce that.
We all know what human rights are, right? It's about fairness. Or is it freedom? Or was it justice? Truth is, it's all these things and more. You see, back in 1948, the United Nations adopted the Universal Declaration of Human Rights. A collection of 30 articles which set down what every individual and every society should recognise and respect, so we are all treated in the way we are all entitled to. Because human rights don't just apply to people on the other side of the world. Human rights belong to all of us in Scotland. You, me, your family, your friends, everyone. That's because human rights impact on our day-to-day lives. At home, at work, in schools, on the street, everywhere we go. And while Scotland has a pretty good track record of human rights in terms of law and policy making, this isn't always true of our everyday experiences. Unfortunately, many people in Scotland are unaware of how human rights are relevant to them. Everyone should be treated with dignity, whether they're in a care home or their own home. Everyone should be respected for who they are and be able to be everything they can be. And no one should have to choose between feeding their family or heating their home. That's what SNAP is about, Scotland's National Action Plan for Human Rights. Over the past 4 years, the Scottish Human Rights Commission has worked to understand how much people can realise their human rights. As well as gathering lots of evidence, the Commission has brought together organisations from across the country to develop a roadmap for human rights. And now the real journey begins. This will mean that we can all participate in the decisions that affect our lives and the communities we live in. Through SNAP, the government, local authorities, as well as services such as the NHS, voluntary organisations, and even businesses can focus more on their human rights responsibilities. SNAP will help them look at ways to respect, protect, and fulfil human rights in everything they do. SNAP shows Scotland's ambition to be an example of how to realise human rights and tackle injustice at home and abroad. Everyone can get involved in SNAP and everyone can benefit from it. For a better culture, better lives, and a better world. And who can say fairer than that, right?
And again, some of the issues that I've mentioned there, I'm not going to pick up on. I will pick up on, however, the culture change issue, which is required. And that cultural change will be required through all levels of service planning, design and delivery. And a part of that's a complex of bringing together a health service. Itself having many culture clashes, I have to say, within it, onto a social care service that has a quite distinctive culture. And an issue amongst recipients, people who are involved in health and social care around the particular model of care. And big worries about how we're going to square that circle, about whether it's a medical model of care or a social model of care that's going. And again, crucial to all of that. That process will be the issue of how you support a workforce through the next process, the next stage in the process as the two organisations come together. And one of the things that we want to do, and the Alliance wants to do in that space, is to create what we've called a resource-light, partnership-driven health and social care academy for Scotland. And that's a collaborative focus. It's not a place to go for your standard grades or your hires. It's a place to go for some informed thinking, some stimulus, some contribution to what's happening. And we'll be saying a lot more about that later. I just wanted also to flag up to you, before I conclude, some of the issues around building connections. And I've just highlighted some stuff there for you. That definition by Governance International, which goes along with something called a co-production toolkit. That phrase there, which I mentioned in my own speech, but also those range of other things that are out there. That My Conditions, My Terms, My Life is a self-management awareness campaign. Alice is a piece of software that maps local community assets. The service pledge idea for people who are rolling up to give them a stake, in service users a stake in the process. My Diabetes, My Way, again, a service user taking control of their process. A Year of Care, a developing idea that puts a framework around GP practices about how they might loosen up their approaches to care. The Caring Behaviours Assurance System, a ward-based approach to try and make sure that caring behaviours are reasserted in the system. Social prescribing, all those things you do that sends people who have long-term conditions back into the community, and other items there. And many of those there are resources that will take you forward. And I'm just, in conclusion, now going to say a few things. There's no doubt that the integration of health and social care and the development of self-directed support sits alongside the drive for person-centredness that I've been suggesting as the three essential facets of public service reform. And all of that stuff works in the context of what is already a considerable platform for progress over the last 18 years. And although I've been suggesting there have been disjoints, I'm also positing to you that much of the activity I've been talking about exists currently in the system. Self-management, co-production, self-directed support, community-led health, personalisation, independent living, asset-based approaches, shared decision making, housing stock transfer, mutuality, human rights. And we can all build on a magnificent set of local examples, and there are a huge number of them in this community. We can build on those examples of spend to save investment and support. We can build on the network of community organisations within VASA and beyond VASA. We can build on the sunk investment that's been made in communities, in social capital, in those deprived communities and elsewhere that exist. And we can affect a more fundamental transformation of change in services. But we need to go harder and we need to work more in partnership. And that partnership work extends beyond statutory services. It extends beyond health service and social care services. It moves into community health. It goes into beyond acute and primary care health. It involves housing, and it involves a whole range of non-statutory interests that make vital contributions locally, unpaid carers, independent and third sector providers, and the extensive range of ways in which community and voluntary organisations are supporting older people in a variety of ways. And make no mistake, achieving that effective partnership working is at the heart of delivering good outcomes for people. I think, finally, Chair, as the public debate on the future of Scotland grows, and it's going to grow exponentially throughout the course of this year, we need to be shaping a future through this legislation in which people, be they older, be they disabled, be they living with a long-term condition, are equal, active citizens who have access to public services that enjoy high quality of life, who live independently, and as we all engage with that panoply of activity that's going to be involved in that, we must make sure that the focus remains on the reality for people, family and communities, and that their voices are the driving force for change. Thanks very much.